So previously we talked about cardiac muscle cells and how their action potential looks and how we can kind of affect the strength of their contraction with calcium. Well, the job of cardiac muscle cells is to contract, and ultimately that determines what we call stroke volume. Pacemaker cells determine heart rate, cardiac muscle cells determine stroke volume. And so with that, we've got these four outcomes that we're going to get through. So to start off, like we do with many of these videos, we've got some definitions. So we've got end diastolic volume. So end diastolic volume is the amount of blood in the ventricle at the end of filling or relaxation. Remember, diastole means relaxation. Okay. Then we've got end systolic volume. So this is the amount of blood in the ventricle at the end of emptying or at the end of contraction. Then we've got stroke volume. Okay, so stroke volume is the amount of blood that leaves the ventricle during a single systole. In other words, how much blood does your ventricle pump out during a single contraction? Simple mathematical formula, end diastolic volume minus end systolic volume. We express stroke volume in terms of milliliters of blood. And then we've got venous return, and we'll talk more about venous return later on in this unit, but venous return is just at the rate at which blood returns back to your heart. So here we've got a diagram, and you're actually going to see this diagram in future videos here, incorporated into several other figures, but this shows us ventricular volume. And so notice at the top, at the maximum, that's end diastolic volume. At the bottom, that's end systolic volume. One thing I want you to pay attention to is notice that end systolic volume doesn't go to 0. It goes to about 50. So it's about 50, 60% of what maximum or end diastolic volume is. So this leads us to preload. Okay, so preload is the amount of force that your ventricle is experiencing during diastole. Or in other words, how stretched out is your ventricle when it's filling up? Okay, this occurs due to the volume of blood that's in your ventricle. So preload is directly proportional to end diastolic volume. If you have more blood returning to your heart, you're going to fill your heart up more and you're going to have greater preload. What's really interesting is that preload causes your cardiac muscle cells to stretch out, but they're different, and we'll show a figure here in just a minute. They're different than skeletal muscle cells. When skeletal muscle cells are stretched out, they don't produce as much force. However, cardiac muscle cells produce more force the more stretched out they get. And we can see that from this figure here. Okay, on the x-axis, we have end diastolic volume. That's kind of a measure of preload. On the y-axis, we have stroke volume. Okay, notice that up until a point, as we stretch out the muscle, we get more and more contraction or more contractile force, and that's shown by the greater stroke volume. Obviously, there comes a point, but unlike skeletal muscle, it doesn't drop all the way back down to 0. It kind of plateaus. Okay, so skeletal muscle cell, more stretch, fewer cross bridges, less force. Cardiac muscle cell, more stretch, more cross bridges, more force. Up to a point, but it doesn't drop down to 0 like in a skeletal muscle cell. Okay, so stretched out cardiac muscle cells produce a lot of force. Okay, and this relationship here is what we refer to as the Frank-Starling Law. These two discovered this relationship. Okay, so they're just showing the relationship between end diastolic volume and stroke volume. Okay, so ventricular contractility. This is known as inotropy. So basically it's just how hard is the heart going to contract for a given level of preload, or how hard is the heart going to contract for a given end diastolic volume. So we can have positive and negative inotropic effects. Okay, they all affect contractility. A positive effect increases, a negative effect decreases. So factors which have an inotropic effect, the sympathetic nervous system, notice that it is underlined, that is for a specific reason that we'll get into. Specific changes in ion concentrations, and then specific drugs. They can open channels or they can block channels. Okay? So what happens if we have a sympathetic response? How does that affect cardiac muscle cells? This causes norepinephrine to be released from postganglionic sympathetic neurons. It binds to beta-adrenergic receptors on cardiac muscle cells. This is the exact same as what happens with pacemaker cells. Here's where it gets a little different. This activates the G-alpha-S pathway. We talked about that a few weeks ago. Ultimately, this leads to stronger ventricular contractions. Okay? And the reason why is it has to do with the calcium ATPase pump. We talked about this in the skeletal muscles, or when we were talking about skeletal muscle. Well, it's the same with cardiac muscle. Okay, so GTP and alpha in this pathway will activate adenylate cyclase, which will lead to more, the production of more CAMP. CAMP will activate protein kinase A, and what protein kinase A does is it increases the activity of this pump. So as a result, more calcium is taken back up into the sarcoplasmic reticulum. Okay, that might seem a little counterintuitive because you're like more calcium in the sarcoplasmic reticulum, that leads to fewer cross bridges. That is true. Okay, but what happens is the next time there's an action potential and the sarcoplasmic reticulum opens up, more calcium is able to be released because there is a larger gradient between the sarcoplasmic reticulum and the sarcoplasm. Remember, larger gradient, larger flow. As a result, more calcium, more cross bridges, more force. And in this case, that more force translates into an increased stroke volume. So a way to look at this, or there's another effect, is how it directly affects an action potential. So norepinephrine also increases calcium permeability during the plateau phase. Okay? So what happens is we get a second peak. We have more calcium going into the cell than we have potassium leaving the cell. But notice the duration of the action potential is much shorter. This is because of the increased activity of the calcium pump that we just talked about. And so as a result, even though we have more calcium coming in, that calcium is immediately pumped out, or more quickly pumped back out into, from the cytoplasm or the sarcoplasm into the sarcoplasmic reticulum. Okay, so we've got this flow chart here that shows how norepinephrine will lead to stronger and more frequent contractions. Okay, and some of you are probably thinking, well, the pacemaker cells determine frequency. That is correct, but we also need to make sure that the muscle cells are in a place where they can experience more frequent contractions. So if we go through this, we'll go to the bottom first. So we increase calcium permeability. So that means there's more calcium in the sarcoplasm, which means more cross bridges. And with more cross bridges, we get stronger contractions. Okay, if we go up to the top, we're going to increase the activity of that pump, which is going to increase the amount of calcium in the sarcoplasmic reticulum. This will lead to increased calcium release, and I probably should have an arrow going from calcium release to stronger contractions. The pump, the increased activity of the pump actually decreases the refractory period. And so as a result, we can increase the action potential frequency, leading to more frequent contractions. So it's not enough to just release more calcium so that the muscle cells can contract harder. We need to put them in a position where they can contract more frequently. They don't contract more frequently on their own. They've got to get a signal from the pacemaker cells, but they're able to respond because they're not in a refractory period. Okay, ultimately, we're getting a greater stroke volume. What does the parasympathetic do? Well, as you can tell from this figure here, nothing. And that's why a few slides ago, I just had sympathetic underlined. The parasympathetic nervous system really has negligible effect, so we're just going to call it no effect on cardiac muscle cells. Its job is to affect the heart rate. So at the end of this video, can you do these three things? Can you define inotropic agent, describe the role of the calcium ATPase pump, that's CIRCA, and can you describe how each branch of the autonomic nervous system alters stroke volume?